follow-up for my presentation, my video presentation titled Towards a Better Understanding of the Problem of Pulp Calcification, Stones, Denticles, and Opacities. The content which I'm presenting is of a great relevance to prosthodontists, endodontists, restorative dentists, and general dentistry practitioners. I'm going to introduce the 10 pulp chamber diagnostic imaging factors. I call them DIF, specifically related to pulp stones and other types of calcification. And then I'm going to show some pulp chamber anatomy, histology, and focusing on the chamber calcification and the root canal calcification. So what are the 10 DIF? Specifically, when we have pulp stone, denticles, and other types of calcifications. These are the factors that influence your diagnosis. These are the factors that every professional looking at radiographs should focus on when they look at the specific tooth of interest. What affects our interpretation of the radiograph and extrapolation of the diagnosis or the pathology condition is first the imaging method. The imaging method here, I am very biased that for pulp chamber, restorative, endodontic, periodontics, it has to be the PA and the bite wing. Nothing else. That is because of the insensitivity and accuracy of the OPG. Believe this or not, this is a radiograph of this patient, and these are the actual PAs of this area here. So the diagnostic method is very important. The imaging method is very important. Another factor is the patient age and the tooth type when it comes to DIF. Anterior versus posterior. The chamber anatomy integrity is one of the very first criteria we look for. The integrity of this outline. Specifically, when you have a bite wing. The next one is the anatomic integrity with pathology. The previous radiographs were normal, healthy pulp. These pulps have been invaded by pathology. Here, this could be internal resorption or caries. This is definitely internal resorption which has extended and perforated. Every single slide you see in this presentation is my own and I have treated. This is caries affecting the pulp horn here. And this is a pulp chamber which has receded to non-existence almost because of the presence of a crack underneath that amalgam. Image radiolucency and image opacity. These are important factors. The radiolucency, that's normal. Opacity, abnormal. So the image opacity, in this case, we have the opacity surrounded by radiolucency, free pulp stones, denticles, surrounded by soft tissue, radiolucency. We call them denticles. So between the free pulp stones and the unattached denticles, two different diagnoses. And underneath that, there is a possibility of doing a standard endodontic treatment. Chamber location and chamber size. Where is the chamber? It's no longer in the center of the clinical crown. It has receded almost to the gum line, the cervical zone. That is a pathology. The same situation here. here, and here the size of the pulp chamber is gone, non-existent. Whereas just next door, we see a pulp chamber. And that's my problem when people talk about calcification being normal, physiologic aging process or otherwise. Why hasn't this pulp aged like this one? The reasons, we have some cause. We have some etiology causing this pulp to disappear. The next item, DIF, is what I call the neighborhood item. What's a neighborhood? Actually, what I mean is the adjacent structures. The neighborhood here is the pin, and pins create cracks, and this creates the calcification you see here. This is, the neighborhood is caries. The neighborhood here is pulp cap. The neighborhood here is a provisional restoration, meaning coronal leukoleakage. So we need to look at the neighborhood, the adjacencies to the pulp chamber. And then we should look also to the external. So we can't count two neighborhoods, inside the tooth, inside the clinical crown, and outside. And the most famous one outside that causes pulp calcification is periodontal disease. Periodontal disease affects the roots more than the pulp chamber. And this is what you see here. This is internal, and this is external. Caries, periodontal disease, proximity to restorations. Here are the factors for your record. Now let's look into the pulp chamber internally. Let's look at some anatomy. This is an impression of a pulp chamber we did at USC many years ago. Silicone impression, and then we dissolved the dentin, the enamel, and everything. And we got samples of the pulp horns. You see them here. We got a cervical pulp horn. You see the outline. That's what I'm talking about, the integrity of the outline. This is a sign of normalcy, sign of health. When these pulp horns beginning to disappear or recede, that is a reason for that. This is now the size of the pulp chamber on a maxillary molar. You can see now how massive the pulp chamber size is. And when this pulp chamber is filled with connective tissue, defensive tissue, healthy tissue, it will fight. It will fight the injury, the restorative injury that it gets, the caries, the attrition, the erosion. But when this pulp chamber has receded and the pulp tissue is no more, the response is totally different. Let's look at the mandibular teeth. This is the image, this is the actual, the pulp chamber cross-section right at the cervical zone. And look at the size. And you see the canal orifices in each one of them. Then let's look at the histology. The classic, the dentin, the predentin, the odontoplastic layer, highly specialized cells, rare cells. Once they go, they never come back. And then this cell-rich zone. With that, you have the neural plexus and the vascular plexus. And then, of course, we have in all of this stroma, you have the connective tissue. But once you have the calcification in the chamber, these tissue become entrapped, strangulated with masses of calcium and other minerals. And with time, and with the gradual irritation continuous, with the low-grade injury continuous, this calcification takes over and you lose the radiolucency and you lose the connective tissue. And this is why we consider calcification as a disease, because it changes the pulp from loose connective tissue to mineral, hard tissue. And the canal is even worse. While here we could use spoons and excavators and tips and ultrasonic to remove the calcification of the pulp chamber, once it's in the canal, it's attached. It's intimately attached, hard to file, hard to remove, and becomes the root canal treatment more difficult. The most important research, in my opinion, is a recent one, recent being 1993, is by, in France, Dr. Lemay, which they did this electron probe microanalysis. And this is very important for us to understand. This is what we call them calcification, because the majority is calcium. And then you have other minerals, phosphorus, fluorine, etc. And we look at these images are very valuable when you correlate them to our diagnostics. We know this is the nidus. The nidus usually is necrotic pulp tissue in the pulp. It's a pulp tiny exposure. Few odontoblasts died, some cells died, and then you have all of this around it. You can see those circles, those layers, and they get bigger and bigger till they block the canal. Dr. Lemay found exactly the same thing in the electron probe microanalysis, and he called them the onion skill aspect. You see them layers, layers. And here you see the nidus, and you see the layering of the calcium and other minerals. And then here you see it around the blood vessels. So the issue is not normal. The issue is very abnormal. And when we look at the pulp stones, this is very important because we see them in young people when we're not supposed to. But there is always an etiology. There is always a cause for these pulp stones. You see here, radiolucency, and here you see the denticles. I developed years ago some curettes. I call them MAR, C1, C2, C3, C4, which specifically they have this long shank. I could see where this spoon excavator is operating. So I could really visualize with magnification to eliminate, to remove the pulp stone or the denticles from the pulp chamber. I need to remove them to enter the canal orifice or to find the canal orifice. Or we could use the ultrasonics. So we finished now the pulp chamber. Let's go into the canals and its relevance to non-surgical endodontics. The calcification of the canal is different. It's an actual root canal obliteration. This is why I don't like the word obliteration for the chamber. Because in the chamber, I still get in and remove the stones. In the canal is different. This is what I call diffused calcification. It's a linear calcified specules depositing around the blood vessels, around the neural element, around the cells, around the walls. And here you see them around the blood vessels, around the cells, around the neural elements. And what do they cause? Canal calcification is a huge problem to endodontic treatment. It impedes it, it makes it difficult, sometimes makes it impossible. And the most significant result is short fillings, short obturations. And here you can see, because of the calcification and the curvature, we had a ledge in the hands of the clinician. Then we had pathology. Because you remember I mentioned in my presentation on the management of upper anteriors and mandibular anteriors that the apical third the apical third is almost always have remaining canal. It's patent because the pulp died and no longer can close. So you have basically a dead space. And this dead space over here, this dead space creates the AP. It's responsible for 50% of our endodontic failures. And that is a very large percentage. So when you look at the errors, broken instruments, and perforations, they all in 1, 2, 3, 4. But short fillings are the cause of substandard endodontic treatment failures. And they make us require surgical intervention. You see here, we have broken instruments. Here we have a transportation of the canal. The canal totally transported. And of course, the apex, you have also transportation, creating false canals and perforations, creating clinician-made canals. And I usually call these in the names of the clinician. So it could be man-made or women-made canals. And then, of course, in my presentation on maxillary anteriors, we discussed that from canine to canine, maxillary anteriors believe in the calcification you see on single-rooted teeth, but don't believe it on any other tooth. And you see here, we removed the crown. We did not expect this. These pins did the job. Perhaps it was a pulp cap. The bottom line here is impassable calcification for a patient who was in a hospital when I did this diagnostic exploration. Here is a situation, the calcified canals on the buccal prevented this clinician from doing the job. And unfortunately, he did not refer. He simply did what he did. Then the case, going back to the endodontist, came back to me. I retreated the canals. I still was faced with the calcification. And I treated it with the retrofills you see here. Here, there is a calcification I could not go through. That's fine, as long as you do not have pathology. Had I have pathology, I have to interfere. And the same situation here, this calcification, we are forced to do an epicoectomy, deep epico, to remove the unfilled canal remnants and the pathology. The same situation here. This clinician did this, hoping that this calcified, no pathology, sure things develop pathology. And then I had to do a retrofill, and here's the healing. So, what's the bottom line? I would like to conclude with few statements. The pulp is the heart of the tooth. The chamber is the heart, and the apex is the lung. So as long as you have a good pulp chamber and a good apex, unclosed, then you have a very potent pulp with great recovery potentials. I want you to know that PCC causes chronic pulpitis, and that affects the pulp recovery potentials. And the recovery potential is basically repair and healing of the pulp. I want you to know that standard endodontic treatment is possible, predictable, with cases with pulp stones and chamber denticles. Remove them and you can do a root canal. And that, at the end, in multi-rooted teeth, do not believe calcification on x-rays. Always explore, clinically explore. Thank you for listening.